Okay. Are we good, Maureen?
You are great.
There we go. And I also have it on my big screen over here because my eyes are bad. So if you see me looking off to the side, I apologize, but helps me to stay on focus. And having to follow Colleen is a real challenge for anybody, you know. I'm sure she's a hard act to follow, but I need to say more than that. She's an amazing woman who has made significant contributions to the practice of case management. So I thank her for her presentation this morning. Now, this morning we're going to talk about hepatic encephalopathy and liver disease. And this may not be on your list of things that you want to know about. But as we talk about readmissions, these folks who have hepatic encephalopathy go through the revolving door of readmissions and really impact our ability to help them find their way through the twists and turns of healthcare delivery in America. So that's what we're going to talk about. But first, we're going to talk about the liver. And also, before we move forward, both Colleen and I have a number of initials behind our name. Colleen has them because she has worked extremely hard and gained lots of recognition. I have them because I help people prepare for certification exams. So most of mine are associated with different certifications you can get in case management. But the one I want to talk about is FCM. A number of the leaders in your organization have achieved this fellow in case management or case management fellow. Colleen has achieved case management fellow. I would like to encourage all of you who have made a contribution to the practice of case management to consider becoming a fellow. Now, applications are closed for this year, but start looking at that application. Look at it for next year because we need to grow this community of fellows. For years, I've been saying that case management is the best kept secret in healthcare. I would like to say that that has changed over the past many, many years. But in truth, lots of folks don't know what case management is. And if we get that recognition as a fellow, I think that the healthcare community, the professionals we work with, the patients we care for, will have a better understanding of what we do. And we're going to talk a little bit about that later. So what are we going to talk about today? We're going to look at the physical and psychosocial impacts that a diagnosis of hepatic encephalopathy, and I'm probably going to call it HE. What are those impacts on the patient, the families, and the caregivers, as well as healthcare delivery systems? Consider how frequent recurrences of HE may cause non-reversible patient organ dysfunction, resulting in both a reduced patient quality of life and an increased economic burden for patients and healthcare delivery systems. And we're going to look at some standards for transitions of care. These come to us from another organization. We'll talk more about them later. These look at the standards for transitions of care and look at avenues for implementing those standards in patients diagnosed with HE in order to minimize the number of potentially avoidable readmissions. I want to share with you, and this isn't a learning objective, but it's the most important thing I want to convey to you today. HE is a disease of caregivers. It is a disease of caregivers because these patients, they become confused in the far degrees of this disease. They go into coma. It's almost as if the patient is no longer able to care for themselves. So we're going to see a little video later that demonstrates this. So remember, HE is not only a disease of patients, it is a disease of caregivers. So I have no potential conflicts to report. This presentation was not developed by, nor is it sponsored by any pharmaceutical entity. And I have to do an editorial comment now, and I really apologize for this. But many years ago, pharmaceutical companies brought us lots of information about specific disease states. Many of those focused on the products that they produced. But then guidelines came forward that said you cannot offer continuing medical education, a pharmaceutical company. And the educational opportunities we received from pharmaceutical organizations came down to educational grants. So I think that although pharma guidelines came forward to make sure that there was no influence on the healthcare community from pharmaceutical organizations, I think this has been a gap. And more, I encourage folks to work with pharmaceutical organizations to get them to give educational grants. We're going to talk about one because I think it's really important that the information that they have can be conveyed to case managers, to healthcare professionals, so we have a greater understanding, not only of pharmaceutical products, but the disease state that those pharmaceutical products address. And that's my editorial comment. The content of this program includes and supports information included in the Case Management, Adherence, and Transition of Care Guide, Hepatic Encephalopathy. This guide was published by CMSA in 2023 and was made possible by a grant from Bausch Health, Salix Pharmaceuticals. And it's available for download. And I have it here, you probably can't see, but it has great information about hepatic encephalopathy, and we're going to look at some of that as we go through today's program. So everything starts with the liver. And, as a nurse, and that is my healthcare background, as a nurse, problems with the brain, problems with the heart, problems with the kidneys, those were things that I focused on, and I didn't think about the liver. But the liver is an amazing organ that has lots of different functions. It performs critical metabolic functions, including producing bile, and it converts glucose to glycogen, and it regulates blood clotting, and it produces cholesterol, and it regulates the levels of amino acids in the blood, and it processes drugs and other toxic substances. And this is important for our discussion today about hepatic encephalopathy. It converts ammonia made during digestion to urea. The liver gets rid of ammonia by converting it into urea through a process called the urea cycle. And this allows urea to be eliminated from the body through urine in the kidneys. Essentially, what the liver is doing is it's detoxifying ammonia by transferring it to the kidney so it can be eliminated. These are some of the normal, healthy liver functions. In fact, and this just amazed me as I was doing some research for this program, is researchers have identified over 500 functions that the liver performs. We're going to look at a couple of them. Detoxification, very important for hepatic encephalopathy. Removing ammonia from the blood before it's transferred through the body to the blood-brain membrane. We'll talk more about that in a moment. As I said, it transforms ammonia to urea. It synthesizes proteins for blood plasma and albumin. It converts, as I just said, glucose to glycogen. bile production, it regulates blood clotting, it does some amino acid regulation, balancing amino acids in the blood, removing bacteria from the bloodstream, and it stores vitamins and minerals. So the liver is an important organ. And liver damage can lead to progressive liver disease. And you're going to see highlighted on this slide some acronyms. And I want to explain those to you, and we'll do a little bit deeper dive into them in a moment. But in the past, we talked about non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Well, just last year, folks came together, and the American Association for the Study of Liver Disease came forward with many, many other groups and came up with some new acronyms, MASH and MADSLD. And we're going to talk about those in a moment. But how does liver damage progress to liver disease? Well, liver damage can lead to progressive liver disease by triggering angiogenesis. Angiogenesis is the formation of new blood vessels, and it plays a significant and complex role in the progression of liver cirrhosis. In cirrhosis, the structure of the liver is just disrupted, and healthy liver tissue is replaced by scar tissue. Angiogenesis contributes to this development of scar tissue by creating new, often abnormal blood vessels. And these blood vessels are less effective at delivering oxygen and nutrients to the liver cells. This can exacerbate portal hypertension, or an increase of pressure in the portal vein. And the portal vein plays a really significant role in bringing blood from the digestive process to the liver. Additional damage can also be caused by an inability of the liver cells, or hepatocytes, to regenerate. This can lead to a buildup of scar tissue and ultimately chronic liver disease like cirrhosis. Liver disease can also progress due to the accumulation of genetic mutations within the liver cells. This occurs in the individual cells, causing a gradual buildup of abnormal cells that can eventually progress to cirrhosis and even hepatocellular cancer, we call HCC. And this occurs when the damage is chronic and ongoing. So I threw out those terms earlier. Let's sort of give you a definition of what MASLD and MASH mean. MASLD is metabolic dysfunction associated steatotic liver disease, and MASH is metabolic dysfunction associated steatohepatitis. You know, in the past, we talked about obesity. We talked about fatty liver disease, and there was a stigma to that. So the groups that came together to rename these two conditions focused on taking away the term fatty and including the word steatotic or steatohepatitis. Steatotic means fatty, but it is better accepted by communities who are impacted by these disease states. So what is MASLD? It is a buildup of fat in the liver that has become the most common liver disorder in the United States. In fact, it impacts 2/3 of obese adults and one-third of obese children. And the majority of folks that have MASLD are aged 40 to 60. So this is not a condition only of the elderly. More and more, we're seeing younger and younger people impacted by MASLD and MASH. According to the American Liver Foundation, about 100 million people have MASLD. So we talked about 2/3. Let's give you a real number. 100 million Americans have MASLD. Somebody on this call probably has metabolic dysfunction associated steatotic liver disease. And MASH. MASH is a leading cause of liver failure, prompting an increasing need for transplant. And this costs the United States healthcare system about $100 billion annually. And it's estimated that 9 to 15 million Americans have MASH. And those numbers are only going to increase. According to one estimate, MASH is projected to impact 27 million Americans by 2030. That's only 5 years away. So we need to have a good understanding of what these are. MASLD is asymptomatic and frequently undiagnosed. And the diagnosis of MASLD requires liver steatosis, that fatty liver, together with at least one of 5 cardiometabolic criteria. So here's the criteria. You have to have a fatty liver plus impaired glucose regulation, type 2 diabetes, you have to be overweight or obese, you have to have hypertension or dyslipidemia. So if you have a fatty liver and you're obese, you probably meet the criteria for MASLD. And diagnosis can be made by looking at, and it goes underdiagnosed. And I think this is my biggest concern. If we can do something about liver disease, if we cannot progress to cirrhosis of the liver, let's try and diagnose this earlier. So what can we do? It can be diagnosed by a number of blood tests, CBC, liver function tests, lipid profiles, fasting blood sugars, hemoglobin A1Cs. There's also some imaging tests that can be done. And I know that we're not doing these regularly on patients, but if a patient is at risk, we might want to look at an abdominal ultrasound. We might want to look at a CT or MRI. There are some tests now, some ultrasounds that look at the fibrous state of the liver. So what can be done? And then we have another term, MET-ALD. This describes folks with MASLD who consume greater amounts of alcohol per week. So we used to have non-alcoholic fatty liver disease. Now we have a term for MET-ALD. Now, MET-ALD really stands for metabolic dysfunction and alcohol-related liver disease. It's characterized by moderate to high alcohol consumption and at least one metabolic risk factors. And we just looked at those metabolic risk factors. And the amount of alcohol that people drink per week, and as I looked at this, I thought, there goes my glass of wine at night every night before I go to bed. 140 grams for women, 210 grams for men. That's the criteria that they're using. And then there is a new drug. And this wasn't really evident to me until I was watching TV the other night. And I see the commercial For Resdifra, I knew nothing about it. This is a new drug. It stimulates thyroid hormone receptors in the liver, which reduces triglyceride levels within the liver. So it's a drug that's used to address MASLD. And I think case managers have to have a greater understanding of this drug. I don't know anything about it. They've never reached out to me or the case management community. But I think it's interesting that there is now a drug specifically designed to address, this says non-alcoholic steatohepatitis. The reason that it says that is because MASH wasn't being used when this drug was approved. If you want more information about any of this, go to the website at the American Association for the Study of the Liver Disease. So, what's the burden of chronic liver disease? And some of these numbers are older. And I tried to get some updates, but there isn't a lot in the literature about chronic liver disease and the burden of them. So the prevalence in 2018, 4.5 million people, or a little less than 2% of US adults were diagnosed with liver disease. And the prevalence of cirrhosis is gradually increased. It's doubled in the past 10 years or 14 years. And healthcare utilization, these people are folks that are impacted by liver disease have a high use of healthcare services, over 1 million outpatient visits and 300,000 ED visits for chronic liver disease in 2014, and those numbers have risen, but I can't give you specifics on them. Cirrhosis-related hospitalizations and related costs have increased from about 5 billion to 9, almost 10 billion. And chronic liver disease patients typically require more hospital-based care than those with other chronic diseases. I need to say that again. If you have chronic liver disease, you require more hospital-based care than folks with other chronic diseases. Yet we do not think about liver disease. Hospital readmissions, the revolving door I mentioned for these patients, readmission rates for folks with cirrhosis, particularly driven by hepatic encephalopathy, are significant. And we're going to give you some specific numbers in a moment. And mortality increased from 11 per 100,000 in 2017 to almost 14 per 100,000 in 2020. We have 60,000 deaths annually. And it's the ninth. It is the ninth leading cause of death. Since I started speaking about liver disease a number of years ago, it's gone from the 11th leading cause of death to the 9th leading cause of death. So this is really a disease state that those of us who are case managers really need to know about. So the complications of decompensated cirrhosis. Well, as a nurse, I always thought about ascites because we drain the ascites, and of course, jaundice. Esophageal varices, folks that were bleeding from the esophagus. I always thought of those, but I didn't think about renal dysfunction. You know, it's interesting that Concerto was one of the sponsors. This is new information to me. Renal dysfunction, portal hypertension, and elevated pressure in the portal venous system can cause problems with the kidneys. In fact, hepatorenal syndrome occurs when there are narrowed and constricted blood vessels in the kidneys. And this occurs in response to liver failure, which reduces the blood flow to the kidneys. So renal dysfunction, cardiovascular dysfunction, uh, all complications of cirrhosis. But we don't talk about hepatic encephalopathy. And yet, up to 80% of patients will develop HE, ranging from minimal to overt. And we're going to talk about how we grade hepatic encephalopathy shortly. But important to remember that HE is a primary complication of decompensated cirrhosis. So what is HE? Hepatic encephalopathy, this is the definitions I want you to look at. Hepatic encephalopathy is a progressive cognitive disorder caused by liver insufficiency or portosystemic shunting, which manifests as a wide range of neurologic or psychiatric impairments. This is the definition that we commonly look at. It is a reversible neuropsychiatric syndrome encountered in patients with cirrhosis of the liver. And it has increased, and we've just talked about those numbers. This is an old study that came forward that talked about 200,000 folks by 2020. It's much higher than that now. It can occur in 30 to 45% of patients with cirrhosis. And the cognitive impairment that is associated with HE, and I know I haven't given you signs and symptoms of HE yet, but we're going to get there. Stick with me. Cognitive impairment that is so common in HE results in the utilization of more healthcare resources in adults than any other manifestation of liver disease. This is a disease not only of patients, but caregivers, because the patients have cognitive impairment. CMS has implemented now ICD-10 code specific to HE. And I want those of you who work in acute care, those of you who work in managed care, those of you who work in post-acute care, to be familiar with this ICD-10 code. Because when you see that, I want you to be aware that your patients need even more support from the care coordination community because of the challenges that they face as they move through the healthcare continuum. Frequent frequent recurrence of hepatic encephalopathy and subsequent readmissions may lead to non-reimbursable organ dysfunction, resulting in a significant decrease of patient quality of life and an increase of healthcare burden costs for patients and facilities. And suddenly my computer is stuck. Where we go. So, adults with overt HE, and overt HE is grades 3 and 4. We're going to talk about that in a moment, but the symptoms that come with overt HE typically include somnolence, being drowsy, going to sleep, to semi-stupor, and even leave to coma. Responsiveness to stimuli may be decreased. They're confused. They may have gross disorientation or bizarre behavior. And let's look at the resource patterns with that overt HE. Among adults with overt HE in Medicare population, now remember, not everybody with HE has Medicare. A number of folks are much younger, not eligible, haven't got Social Security disability income or supplemental security income, so they may not be eligible for Medicare. So we have to look, do they have private insurance? Are they still working? but this just looks at the Medicare population. 63% had at least one long-term care stay. 95% were transferred to a SNF from an inpatient stay. And after they were in a SNF, 19% were admitted back to the inpatient hospital stay. And we'll talk about some of the reasons why. Inpatient readmissions within 30 days of a skilled nursing facility discharge were commonly related to overt HE. 35%, 36%. So as I said, this is a disease that keeps on giving. And one of the challenges is, and again, this is my opinion only, is that there's not a good understanding throughout the healthcare continuum of what overt HE is, the confusion that comes with it. Often these patients are assumed that they have some kind of memory impairment caused by dementia, caused by Alzheimer's disease, when in fact, it is the liver dysfunction that is promoting or prompting the development of this bizarre behavior that we sometimes see. And there's increased mortality in folks with that grade 3 or 4 OHE. They have 30-day higher mortalities versus lower grades of HEs. And among about 25,000 patients with cirrhosis hospitalized HE, 32% were admitted within 30 days. We heard Colleen say average 14%. This is almost double that, or more than double that. So here's more about readmission rates. Recurrent HE underlies elevated rates of readmission. 53% of patients with cirrhosis experienced more than one readmission within 90 days, with HE as the primary reason for readmission, and 36% of patients with more than 3 complications of cirrhosis: jaundice, esophageal varices, ascites. 38% of patients that had more than 3 complications of cirrhosis were admitted within 90 days, with HE as a significant predictor of 30 and 90-day readmissions. And as we heard Colleen talk, we had a focus on Medicare, but remember, it's not just Medicare for these patients. They may have commercial insurance. And one of the measures, the HEDIS measures that, and if you're not familiar with HEDIS, it's a measure that comes from NCQA, the National Commission on Quality Assurance, which works with credits insurance organizations or managed care organizations and a number of other groups. Well, NCQA has this HEDIS measure that looks at 30-day readmission across the spectrum of insured lives. So these patients, you know, as Colleen was talking about managed care or managed Medicare, they may not pay for that second admission or that readmission for patients with HE. And some of the factors that contribute to HE-related readmission include caregiver burden. How is the caregiver doing and taking care of this patient? We're going to look at a video in a few minutes. Hopefully it'll work. That really looks at what caregivers experience. You're going to see a picture or a video that shows patients, and we'll talk a little bit more about that later. A lack of follow-up, failure to prescribe prescriptions. Now we're hoping with some of the changes in Medicare coverage for drugs that came forward in 2025, that maybe the cost of medications will be reduced, so that won't be as large as a factor in patients not taking their medications, but failure to refill their prescription, failure to remember to refill their prescription because of their disease state, because their lack of memory, a lack of follow-up. Colleen talked about the fact that I live in a rural community, and I have to share a little story. I live in rural America, as Colleen said, and I live in a zip code that covers, are you ready for this? 163 square miles, 163 square miles. My mailing address is Whitwell, Tennessee. Yet the real town of Whitwell, Tennessee is 20 miles from where I live. But they deliver my mail, so that gives me a town address for my mail. So as a case manager in acute care, I may see a zip code and say, oh, Nancy lives in Whitwell. Let's send home health care services from Whitwell to Nancy's house. But there are healthcare providers, home health providers that live 20 miles the other way from Whitwell that have a Whitwell mailing address. So that means the healthcare provider, the home health agency, would have to come 40 miles to my house. How did this impact a member of my community? A neighbor. Husband was in the hospital, diagnosed with end-stage cancer. They arranged hospice. Well, the hospice they arranged was 40 miles away from where we live. And they said, oh, we can take care of this patient. But they couldn't. And ultimately, even though he had a desire to die at home, he was readmitted to the hospital because of the lack of services. Interesting fact, 14 miles in the other direction, in a different zip code, in a different town name, there's a hospice that could have provided services. So we have to look at not only what's wrong with the patient, but where does the patient live? And I'm suggesting, and this, I'm sort of giving this away, but that's all right. I just wrote an article for care management, which is case management. That's all right. I'm not good with names. I apologize. The CMSA magazine, and talking about the fact that maybe we need to start having patient questionnaires about where they live. That could even be built in to electronic medical records, or a healthcare records, whatever we're calling them today. So that, when I go to the doctor, they ask me to fill out major forms. Why don't we have patient generated forms about where they live or any challenges they might experience it, rather than having to do it patient by patient? And that's an aside, and I apologize for bringing that up, but it really impacts readmission rates. Where does the patient live? What's their biggest concern? What kind of social support do they have? Do they understand the words we're using? When we say hepatic encephalopathy, what does that mean to them? We say that the confusion that arises secondary to your liver disease or because of your liver disease. And what are some of the other disease states? These patients do not live alone with one diagnosis, and it's probably not the best way to say that, but they have multiple diagnoses in addition to liver disease, in addition to HE. What are those factors? These are the clinical features of hepatic encephalopathy. Attentional alterations. I can't focus on things. Psychomotor speed and visuospatial ability. We all have driver's license, or the vast majority of us do. If we have diminished psychomotor speed and visuospatial ability, can we drive? And I'm going to tell you a story about driving. So very important for a lot of things we do. What if our work involves some kind of use of machinery and our psychomotor ability impacts those. Alterations in consciousness and motor function. And I'm going to ask you to look at my picture now. Not that I like looking at it. In fact, I turned it off so I can't see me. But I want you to look at this. One of the typical signs of HE is asterixis. And if you've never seen asterixis, this is it is. You ask the patient to put their arms out as if they were telling someone to stop. And then is there flapping of the hand? That's asterixis. Is their memory compromised? Are there personality changes? Do they have apathy, irritability? Are there disturbances of the wake-sleep cycle? Are they awake more at night? Some of the symptoms driving them down: anxiety or irritability, cognitive impairment, shortened attention span, that asterixis, muscle twitching, reduced alertness, sleep problems, slurred speech, behavior or bizarre or inappropriate behavior, and in the later stages, coma. Why does this occur? Well, there's a toxic accumulation, most commonly of ammonia, that occurs. And remember, there's an inability of the liver to change ammonia to urea, to send it to the kidneys to get it removed from the body through urine. But when it's not removed, it goes and impacts the blood-brain barrier. And that impacts the astrocytes in the brain. And when the astrocytes are impacted, they are unable to function appropriately. Part of their job is maintaining that blood-brain barrier. And then neurotransmitters are impacted. So this produces the signs and symptoms of HE that we see. And coma. A number of you have worked in acute care and have seen patients with liver disease experiencing coma, most associated with hepatic encephalopathy. And what are some of the triggers for HE? Binge drinking, constipation. We're going to talk about some of the treatment for HE in a moment. But one of those treatments is causing waste from digestion to move more quickly through the digestive tract. Because if we can move things more quickly, there's less time for the blood to absorb ammonia. So let's move that through. When we're constipated, the feces don't move as quickly through the GI tract, and there's more time to absorb pneumonia. Other triggers: GI bleeding, infection. Infection is a major trigger for hepatic encephalopathy. Kidney disease, portosystemic shunting, reducing the ability of the liver to obtain blood from the body. Hepatic cellular cancer, medication non-adherence. Colleen talked a lot about non-adherence. Why aren't you taking your medication, patients? We'll talk more about that later. Electrolyte imbalance. When we're having waste products move through the digestive tract more quickly, can it cause an electrolyte imbalance? Is there thrombosis in the portal vein? Respiratory distress. Medications that impact the nervous system might be not only a trigger for HE, but may prolong the time that the patient is in coma. So if a patient comes into acute care with grade 4 hepatic encephalopathy when they're in coma, we don't want to give them opioids or benzos or antidepressants or any psychotic agents. Well, most importantly, opioids in acute care, because that can prolong the time that they're in coma and any sudden change in diet. We're going to show you the movie now. Hopefully you can hear it. If there's any challenges, please let me know, because I think this is really important. Oh, shit.
Nancy, there doesn't appear to be any sound.
Was there a problem, Maureen?
There was no sound.
I am so sorry.
Hmm.
Well, I will tell you about it because now my screen has gone wonky on me. So we will try again. Um, there's always a challenge.
Always, always, always.
All right, because I have the gallery in my screen. Okay, there we go. All right. I am so sorry that you couldn't hear that, but I will. There. Oh, it did it again, and for some reason, there we go. All right. Are we back on screen again?
Just you, not your slides.
My slides are not there.
No.
Well, let me get rid of me if I know how to do this. Uh, you know what? I am having a challenge.
Okay, let me see if I can pull up your slide deck and then we can find where we're going. and then I can give you control.
All right, let me try one more time. I think I got it.
Okay.
Maybe not. Have we got?
Okay. You got the slide.
All right. Um, you could read what it said, but and I apologize that you couldn't hear the sound.
I
I
can
don't.
send the link.
Yes, please share the link. This is a video that came from a program that was put forward by Salix Pharmaceutical. They sponsored it, and hopefully that I'm going to do something that doesn't compromise where we're at right now. Because you're still seeing, you're not seeing, I'm going to go to the next slide. Maybe that'll work. I am, there we go. There's the next slide. We okay? Can you see that now?
Yes.
All right. And, all right, I'm going to go back. And I'm sorry that I am having problems, but life goes on, and like Colleen said, I have to change the view. It'll just take me a minute. All right. We're going to go with what we got now. And I apologize for this. I don't know what happened, but life goes on. So let's talk about how we come up with criteria to grade HE, because I think that's very important. What stage of HE do they have? And I'm going to go back to the video just for a moment, now that I've pulled myself back together again. Okay, what that video showed is the fact that families are very engaged in the care of the patient with HE. And I'm sorry you couldn't hear it, but when the woman is talking about her husband and she says, you know, I don't want your son finding you in the bathroom dead. And he says to her, then don't take care of me. Her response is, you can't take care of yourself. You can't take care of yourself. And this is what happens to patients with HE. They can't take care of themselves, and that's why we call it a disease of caregivers. So, here's the criteria that looks at HE. Minimal. There's no symptoms, only can do psychometric testing, grade 1. A lack of awareness, euphoria or anxiety, shortened attention span, impairment of the ability to add or subtract, and altered sleep rhythm, grade 2. Lethargy or apathy. We saw, even though you couldn't hear it, you saw the man laying in the bathtub. Lethargy or apathy, disorientation to time, personality changes, inappropriate behavior, asterixis. Grade 3, somnolescence to semi-stupor, sleepiness to semi-stupor, responsiveness to stimuli is decreased. They're confused. They have gross disorientation, bizarre behavior. And grade 4 is coma. I'll tell you a little story about one of the patients I worked with. She was a young woman. She was only in her 30s, but she had severe cirrhosis of the liver. And she didn't have fatty liver disease, or as we now call it, MASLD. And she was telling me the story about how one day she was taking her family members to the airport, and she even stopped to get a McDonald's on the way because she didn't want them to be hungry on the plane. And she got to the airport, and she turned around, and there was nobody in the car. She had been hallucinating. She had gross disorientation. She ultimately lost her driver's license because she would drive the wrong way down the street. If the speed limit was 50, she'd drive 80 or she'd drive 20. So complete confusion, inability to perform daily tasks that we all do. We're going to talk about treatment in a moment. But she was referred to a transplant center because the degree of liver dysfunction had gotten to such a degree that she required transplantation. The case manager, and I'm very proud to say this, the case manager at the transplant center said, let's look at your medications. Let's see what medications you're on. And she identified that adding additional medication to her treatment regime might control some of the signs and symptoms of HE that she was experiencing. And it made a difference. And it made a significant difference for her. And she could manage her disease much more appropriately until she came to transplant. So what is the treatment of HE? What are those precipitating factors? Things like constipation. How do we limit those? And what medications are appropriate to treat HE? So here's a slide that looks at the management of overt HE. And if we go back, and I apologize to do this, but if we look at overt HE as grade 2, 3, and 4, signs of lethargy, personality changes, inappropriate behavior, asterixis, sleepiness, confusion, bizarre behavior. If we look at those, how do we manage those symptoms? How do we treat that degree of illness? Well, supportive care. What kind of supportive care do they need? And support may be, as Colleen talked about, home health care, going into the home to see what's going on. What kind of supportive care can we give them? And we're going to dig deeper into treatment in just a moment. Is there any other diagnosis that is prompting the signs and symptoms of overt HE that we see? What are the precipitating factors and how do we treat it? And in initial episodes of overt HE, typically patients are prescribed lactulose. Lactulose causes waste products in the GI tract to move more quickly. So if they're moving more quickly through the GI tract, less time for the body to absorb ammonia. And it's titrated so that the patients have 2 to 3 bowel movements per day. One of the challenges with lactulose is it tastes terrible. And sometimes patients are reluctant to take enough lactulose to affect those 2 to 3 bowel movements per day, or they forget to take it. I don't know about you, but I take very minimal medications per day. Oh, and I forgot to tell you, today is my 56th wedding anniversary. So my husband is being very supportive in the fact that I'm doing this morning. So when we say, well, thank you. When we say 56 years, y'all know that I'm wise and seasoned, which is my way of saying I'm old. Well, I only take a couple medications per day. One of my challenges is I have macular degeneration, and so I have to take eye drops 4 times a day. Well, think I will remember to do that? How important is sight? And I still forget some days that, did I take it 3 times? Did I take it 4 times? Did I even take it 2 times? So for these patients, having some kind of tools, and Colleen mentioned some of those. Even having your cell phone, and all of us have cell phones, and do we even ask our patients, do you have a cell phone? That's something maybe we have to start doing when we're assessing our patients, so that they remember to take their medications. If there is a recurrent episode of HE when the patient is on lactulose, we need to look at maybe adding an additional medication to the treatment regime. And that additional medication is called rifaximin. This is a drug that was developed by Salix Pharmaceuticals that sponsored the CMAG book that we're going to talk about later, a little more detail. Rifaximin is given to address the bacteria in the gut that add to the development of ammonia. So, two-arm treatment of overt HE from a medication viewpoint, we look at lactulose and rifaximin. Here you see first-line medical treatment. Lactulose lowers ammonia by causing bowel movements, elimination of ammonia-producing bacteria from the intestines, lowers the absorption time, and administered orally or per rectum. Rifaximin, minimally absorbed antibiotic that decreases the risk for additional episodes, decreases ammonia production in the intestines, and because of the bacteria that are absolutely eliminated, and guidelines from the American Association for the Study of Liver Disease and the American Association, the European Association for Study of the Liver. These guidelines state rifaximin is an effective add-on therapy to lactulose to reduce the risk of another overt HE recurrence. And that case manager that helped the patient who had overt HE, who was taking people to the airport that weren't even in her car, she suggested the addition of rifaximin. So, two-arm therapy when there is a recurrence of HE, lactulose, rifaximin. So what is the role of the case manager? I don't know how many of you have seen this. I think your chapter has to be really, really proud of Pat Noonan, because she leads the committee that provides communication. And that's probably not the name of the committee. But we came up with this, a one-pager that can be given to patients that says, this is what case management is. This is what case management is. This is important. I want to spend just a moment. Patients don't know who case managers are, don't know what we do, don't know why is it important. All of this is extremely valuable. So here is where you can get it. Maybe I can ask Maureen to send it out to all of you. But it says who we are. Case managers are healthcare professionals who work with you and your family or caregivers to help you understand and maintain your health and manage your health and your care needs. And up in the upper right-hand corner is from our standards of practice. And again, y'all know that my eyes are bad, so I apologize when I'm leaning in to read things, because I disconnected when we were having computer problems, and maybe this will come on again. Up in the upper right-hand corner is from the case management CMSA, Standards of Practice for Case Management. This is my story, and I don't mind sharing it. About 3 years ago, I was diagnosed with a follicular lymphoma. And I was receiving daily radiation to the site for a number of days. And I was on the committee that was changing the standards of practice. And as I came home from my radiation, I was on the phone and in the grocery store, by the way. And I said, I think we need a consumer-focused definition of case management. And they said, all right, Nancy, you come up with it. So this is what I came up in the dairy portion of the grocery store. Case managers are healthcare professionals who serve as patient advocates to support, guide, and coordinate care for patients, families, and caregivers as they navigate their health and wellness journeys. This is in our standards of practice. This is what we do. This is what we should be sharing with our patients. And I apologize that I'm sort of off track with HE, but if we're going to provide care for patients, we need to tell them who we are, how we can help them in their healthcare journey. In the past, sometimes we have been looked at as a force that is only focused on getting you out of that bed. Get them up, move them out. Do you all remember? No, you're all probably much too young, but many years ago, there was a TV program called Rawhide, and it had a theme song. Oh, Clint Eastwood was young and good looking, too. So, of course, I was, too. Anyway, it had a theme song that went something like this. Get them up, move them out, Rawhide. Drive them in, drive them out, though they're disapproving. Keep those doggies moving, Rawhide. Well, in some acute care facilities, we still use that philosophy of get them up, move them out, Rawhide. Though they're disapproving, keep those patients moving, Rawhide. Case management doesn't do that. We are not concerned about discharge, and here's where I get in trouble. We have to quit talking about discharging patients and talk more about transitioning patients, because that's truly what case managers do. Editorial comment aside. Okay, so I'm going to read you something, and I apologize for doing this, but Becky Perez, when she was with CMSA, wrote this wonderful statement in the Case Management Adherence and Transition of Care Guide for Hepatic Encephalopathy. Adherence in management of any condition is not always easy. There's many reasons why an individual may experience complications, adverse effects, or treatment failures. This component of the guide that she put together will provide much needed information about the case manager's role in supporting adherence to prevent and to treat episodes of hepatic encephalopathy. Case managers have a responsibility to learn about the conditions that challenge patients and apply that knowledge in reducing complications and supporting health improvements. This unique skill set that case managers possess ensure patients with hepatic encephalopathy will have access to education, support, advocacy, coordination of care, and safe and effective care transitions. I also, and Colleen mentioned this earlier when she was talking about ethics credits. The Commission for Case Management Certification, the Commission for Case Manager Certification, put forward a code of professional conduct. Is that me again doing that? That says, board-certified case managers will practice only within the boundary of their roles and competency based on their education, skills, and professional experience. Is that me doing this?
No,
I
it's
hope.
our next speakers joining.
Okay, thank you. Based on their education, skills, and professional experience, they will not misrepresent their role or competency to the patients. Case management competence is the professional responsibility of board-certified case managers and is defined by educational preparation, ongoing professional development, and related work experience. I believe it's important for us to truly understand the disease states of the many patients we care for. So, let's talk about how do we decide who we're going to work with. Which patient requires a greater focus, a more significant involvement of the case manager? So the question I want to ask you is, would a patient who is diagnosed with cirrhotic liver disease benefit from case management intervention with education not only about HE, but about a liver disease and the serious complications associated with that disease, including HE? We need to provide information to families and caregivers regarding the symptoms of HE and review medication to determine if lactulose was previously prescribed. Are they taking it the right way? If you see a patient in your facility who has liver disease and a medication like lactulose, we're going to assume, excuse me, I shouldn't have said that word, we're going to realize that hepatic encephalopathy is one of the challenges that they experience. We need to conduct that biopsychosocial assessment. What physical conditions and symptoms do they have? And not only asking the patient, but taking the time to talk to the families and caregivers. And sometimes we have to talk to the families and caregivers outside of the reach of the patient. And maybe that's a violation of HIPAA and we have to get the patient's permission. But I want to talk to the family and I want to know, what's a typical day in the home? What symptoms is the patient experiencing? Is the patient able to make their own breakfast, to take their own medications, to get to the bathroom by themselves, to answer the phone, to access their patient portal to find out information, to know where their medications are, know when to take them, and know why they're taking them? What's the biggest concern of the patient and family? What is important to them? I've asked these patients, how has liver disease impacted their lives? How is their life different today than it was before they experienced liver disease and hepatic encephalopathy? And what information can I share with them? And remember, we move very quickly now. These patients may stay in the hospital 4, 3, 2 days. How much time do we have to provide education? And that's why it takes a community. It takes all of us working together, not only the acute care case manager and the post-acute case manager, but the managed care case manager. I will share with you, you already know how old I am. I've been married forever. I told you I'm 77. A number of years when I was diagnosed with follicular lymphoma, I called my managed Medicare company, who will be nameless, and I said, I think I need a case manager. And they said, you're not sick enough. I said, what do you mean I'm not sick enough? Well, you have a cancer diagnosis, but you don't have any other needs. They didn't assess me. All they looked at was my diagnosis. So we have to say, all right, managed care company, here's a patient with liver disease that has hepatic encephalopathy who is at risk for multiple readmissions, and we have to make sure there's continuity of case management services as this patient transitions to the next level of care, to the next health care provider, to the next person who is going to touch that person in the healthcare community. And that comprehensive assessment has to include what medications have you been on, what treatment have you received, what was your response to those treatments, how often do you prescribe, did you refill your medications? These are all questions that are very important. And maybe the development of a questionnaire is what we need to do so that we can get that information from the patient. Are there any behavioral mental health systems or disorders? And the health-related social needs that Colleen talked about. This is a whole nother program, and I'm sure you've heard Ellen talk about them. But what are their health-related social needs? And I talk about health-related social needs rather than social determinants of health, because health-related social needs are sort of a subset of social determinants of health. But what are their health-related social needs? And I can say, what kind of things do you need in the home patient? What are you challenged by? What's your living environment? What's your financial status when it comes for paying for your medications? I think it's important to remember, especially for patients who are in managed Medicare programs, that if they're in a program that has few stars, at any time during the year they can transfer to another program that has a higher rating or more stars. So if they're challenged by and I'm going to say this, and I apologize to everybody, but this is how my mind thinks. There are still some managed care companies that are 1-800-HELL-NO companies that are more focused on saying, no, we don't provide it, than saying, what can we need to help you to be successful? So can we transfer that can we encourage that patient and family to explore other options for Medicare coverage?
Excuse me, Nancy, I just want to let you know we're at the 5-minute mark.
Oh, well then I better hurry up. Thank you. So, important things. Can they drive? What's their nutritional status? What kind of triggers have prompted episodes of hepatic encephalopathy? How do they take their medications? And who's the primary decision maker? I really want to spend a moment on CAGE. This is a 4-question screening tool used to identify potential alcohol use disorders in adults. And, if I go to my primary care doctor, they do the CAGE questionnaire. So for patients with liver disease, do we do a CAGE questionnaire? I think it's important. We need to develop a case management plan of care. What challenges are most important to the patient and family? What is the primary goal that the patient, the family, and caregiver wish to receive? And we need to evaluate the results of that care plan on a regular basis. So, coordination of case management plan of care. We know that the Part D out-of-pocket drug spending cap is now $2,000, and that $2,000 can be put in payment over time, so that might help our patients afford their medications if they have Part D or a managed Medicare. Counseling, PT and occupational therapy, a consult to a registered dietitian. In the past we said these patients shouldn't eat protein. They need protein. So what does a dietitian say they should be following as their normal dietary plan? And assisted living or skilled nursing facility, do they understand hepatic encephalopathy? Do they understand what the patient might experience? Because I have found that isn't always the case, and we need to advance adherence. Capacity to drive. Let's have these patients evaluated by OT to make sure that there is fitness to drive. And if they can't drive, what options are available? I told you I live in a rural community. Uber has never been down my road. So what are their options if they can no longer drive and if family can't drive them? Transitions of care, this comes from ACMA, the American Case Management Association. They have standards specifically to transitions of care. And although my heart is with CMSA, ACMA did this, and they have to be congratulated. But this really reflects our standards that say, identify folks who are at poor risk, complete a transition assessment, perform and communicate med rec, and case managers have to be involved in the medication reconciliation process. It just can't be the bedside nurse. It can't just be the pharmacist. We need to have perform and communicate med rec. Establish a dynamic case management plan that meets that patient's needs. And communicate essential transition care information to the key stakeholders. Primary care physician. Are they going to see a gastroenterologist? Are they going to see a hepatologist? Do they see a GI doc? And I will tell you that sometimes when these patients transition home and they can't get a drug like rifaximin, I will, if they're seeing a GI doc, a gastroenterologist, I'll call their office and say, do you have any samples that Mrs. Brown, who is your patient, could get while we transition her and get coverage for this medication? Readmission rates, I put this in, 30-day readmission rates range from 30 to 50%. Patients experiencing HE are more likely to be readmitted to the hospital compared to the other complications of cirrhosis, and 30-day readmission rates for our patients are 30 to 35%. And the primary cause is for patients diagnosed with overt HE is reoccurrence of that HE themselves, often due to poor medication adherence or failure to manage the precipitating factors like infections, electrolyte imbalances, or dietary indiscretions. And sometimes, and this is important, and I know I'm running out of time, but if I run into the question time, that's okay. People can send me questions because I'm going to give you my email address. The patient, these are the Ask Me 3 questions. The patient, family, or caregiver does not understand information regarding their diagnosis. What's wrong with you? They don't know what they need to do about it, and they don't understand the value of adherences and conversely the consequences of non-adherence. Really important. HCAHPS data. This comes from patient surveys after they leave the hospital, and one of the questions is, did people give you information? Did you get information about what to do when you went home? And 82% say, yes, I got information. But only 52% of patients nationally indicated that they strongly agree that they understood their care when they left the hospital. We tell them what to do, but they don't understand how to do it. They don't understand their diagnosis. They don't understand the value of the medications. So, establish a multidisciplinary approach. Hepatologists, physical and occupational therapists, dietitians, pharmacists across the continuum. What pharmacy do you go to? Is there a pharmacist at your pharmacy benefit plan? Can they help you? Social workers. You know, we sort of throw social workers and case management together, but in some places they're very different departments. So is the social worker supporting the patient, not only in acute care, but social workers in post-acute care, in the community? Are they helping the patient? And are there support groups? There's a quick case study, 64-year-old man diagnosed with cirrhosis secondary to MASH, history of variceal bleeding, ascites, and HE. He follows his lactulose therapy, but he comes into the ED anyway with symptoms of confusion, slurred speech, and asterixis. He's diagnosed with a UTI because infection is one of the triggers. and he's prescribed an antibiotic. He's dehydrated. He's hospitalized for 3 days. And here's the discharge plan. Lactulose and rifaximin to address recurrent HE, a dietary consult, a driving evaluation, really important. Referral to a hepatologist or a gastroenterologist, and patient education regarding signs and symptoms of HE, some of the triggers to avoid, and the value of adhering to a medication plan. So we don't have time to discuss this, but what would you do if you had a patient with hepatic encephalopathy? Sometimes and maybe the word shouldn't be would, but what could you do given your role and functions in your current practice setting? These are some of the things that you might like to do that we can discuss, that we can consider as we think about patients who need the support and care of a case manager and as they move through the healthcare continuum. There's no one right answer with these patients. One size does not fit all. Lots of patient education resources. I'm not going to go through them all. These are all free. These are great. Although they are sponsored by pharmaceutical organization, really have good tips. I want to show you one that comes from the VA, because I think the VA, sometimes we criticize them, but it does a great job of explaining what HE is and how HE can be managed and treated. And then there's some additional resources from another organization. So I know I've gone through this quickly. I apologize about the lack of sound, but life goes on. So
Thank you, Nancy. Do you feel like you need to take a deep breath?
no, I can talk fast.
I know, that was awesome. Thank you so much. And in the Q&A, there was a question, but then it said that it was answered. The question was from an anonymous person, and then Cheryl Burgess said that she thought you answered. The question that I saw was about lactulose and non-compliance, but I'm not sure if, but you did somewhat address it, the challenges that go on.
Oh, well, and I encourage anyone who works with a pharmacist or has access to a pharmacist to go and say, can you give me a drop of lactulose just to taste it? Because it is the worst tasting, awful stuff. And we are asking our patients to take 2 to 3 doses per day. And it really compromises their ability, because when you think about having multiple stools a day, how does that impact your life? I had one patient who told me where he knew where every free bathroom was between his home and his job.
Exactly. And I have to say, I'm a total supporter of what you said, the patient form, like what are their challenges, where we all talk about access to care, right? But we talk about it from access from our side of the story, not the patient side of the story. So I love that idea. That's awesome. I want to point out to everyone, there's multiple references in the chat that Maureen added for different documents that were referenced. And I want to thank Mary Mathau. Mary, I'm not sure I'm saying your name correctly, but Mary put a link in for an article related to diabetes and obesity specific to, that's relevant to this topic as well. So please take advantage of all those links that are in the chat. And I do believe that that is everything.
Let's get the next presentation up. Okay, can everybody see my screen now?
Yes, thank you.
All right, so I'm going to start with a disclaimer, right? So today I'm going to be doing most of the speaking. My partner, Michelle LaValle, is going to be here to answer questions in the chat, and she will chime in as she feels needed. And then we have Lauren as well, but I want to start with our disclaimer that we are speaking on our own individual capacity and not on behalf of Adapt Health. Any statements that we make are based on our own individual experiences and not necessarily the views of the organization. So that being said, Michelle, like I said, is going to be in here. She's also responsible for making sure I don't say or do anything silly. So she can't really control what I say. I definitely can't control my face. And she always says I can't. So if my face looks crazy, just realize that I'm just, goofy. But let's talk about discharging patients with NIV, right? So our main objective today is to talk about how we're treating chronic respiratory diseases. We'll go into the NIV coverage, and then we'll speak about managing that patient at the home. Okay, so what are the main diseases that we are talking about? We're talking about COPD, right? Chronic obstructive pulmonary disease, ALS, and other neuromuscular diseases, obesity, hypoventilation syndrome. Those are the main areas where we're treating patients with non-invasive ventilation. And our goals, as always, is anytime you're going to have a good program, ours is called Breathe a Little Easier, but if you're going to manage patients, you need to have some goals in mind. Number one is to reduce the symptom burden and try to present adverse events. So that's what we're trying to do with intervention with these therapies, right? So what do we mean by adverse events? We're talking about exacerbations, hospitalizations, or potentially worse. So I always like to start with the why, right? So why NIV? Why is it important, and how does it help our patients? And so we really can understand what we're doing. So when we talk about COPD, and the main culprit, the 800-pound gorilla on COPD, is obviously not just a lack of oxygen, but it's the buildup of CO2 and the air trapping the patient has in their airway. And this results in the patient compensating with their accessory muscles, which leads to respiratory muscle fatigue. So if we look at our diagram of our patient over here to the right, we can see this nice dome-shaped muscle right above the arrow pointing up. That's the main muscle of breathing. And in a normal, healthy individual, when it's time for the patient to breathe, the brain will send a signal, and that muscle will contract, like in the bottom diagram. And that'll create a negative pressure in the lungs, and air will just passively flow into the lungs, right? In and out, repeat if necessary. And we don't have to think about that, right? The body's going to automatically do that. That just happens. But we're talking about when it's not right, right? And again, as I said, CO2 is the real issue. The problem is we can't get the good air in because we can't get the bad air out. The good air obviously being air with oxygen, the bad air being the CO2. So what happens over time is a patient has COPD, and if they've had it for a while, they trap more and more of that CO2 behind the obstruction that they have in their airway. And that's going to lead to some diaphragmatic flattening if we look on our chart here. So as that diaphragm flattens out, it can't contract. It's already contracted, so it can't contract. It can't create that negative pressure, which will not facilitate allowing that air to passively flow in. Okay, we also lose the elastic recoil, and intrinsic PEEP, or the pressure within those lungs, is going to rise. So again, if air glows from areas of high pressure to areas of low pressure, that's why it can passively flow in. If the pressure in our chest, in our lungs, increases, then it's going to make it more difficult. You're not going to get that passive flow as well. So everything works against us, but the good news is the human body is the most wonderful machine ever built, right? So we can overcome that. In the meantime, our patient's going to have increased dyspnea. They're going to have increased muscle weakness because they're not using that diaphragm. It's going to become weaker, and it's going to have increased work of breathing. because that human body is the wonderful machine, most wonderful machine ever built, it's going to compensate with our accessory muscles, right? Our chest muscles, our intercostal muscles, which are rib cage, obviously, our neck muscles, shoulder muscles, everything it can to physically pull and drag that volume in, because that's what the patient's going to need. But those accessory muscles are going to carry a large part of that load, but they're not really designed to carry that load long term. So just like any other muscle, they're going to fatigue. And when they fatigue, that's when ventilation's really going to drop. That's when their CO2 is really going to shoot up. And that is what we call an exacerbation. And that's when we're going to have to jump in and do something. Okay. So that's what's really kind of going on here. As we talk, so when we talk about ventilation, we're going to talk about why we would intervene. So if the number one goal, that 800-pound gorilla, is this CO2 and that respiratory muscle fatigue, our end goal would be to take care of this, right? And so really, when we think about ventilation, we know about the relation between ventilation and CO2. We're thinking about ventilation equals removal of CO2 from the body, not just ventilation where we think about it in the facility where we're only thinking end of life, right? We're thinking ventilation for the purposes of managing, reducing that CO2, lessening that respiratory muscle fatigue so that patient can continue to breathe on their own, at least to some extent. And so that's what we're really using it for here. And so when I describe this respiratory muscle fatigue, it's kind of like if you go to the gym and you're doing a workout like with a dumbbell, right? So say you're going to do bicep curls. It doesn't matter what the weight is, but you're going to do curls. And at some point, you are going to have done your last curl. Okay. And then once you've done that last curl, you're not going to be able to do any more because you completely fatigued that muscle. That's what's happening a lot of times when we get to an exacerbation. And we all know if we do that, if we wear those muscles out, what's going to happen is it's going to take time for that muscle to recover, for that muscle to heal before we can do that next curl. So our respiratory muscles are no different. What happens is we wear them out, the patient ends up in an ER. And so they're going to get a couple things. Patient goes to the ER with an exacerbation. We're going to put a pulse ox on them. We're going to listen to breath sounds. We're going to find they're not moving air. We're probably going to give them a breathing treatment so that we can open up that airway. Probably going to get some supplemental O2. We'll do a blood gas. Probably going to find we got elevated CO2, so we need to address that. And so we will address that in some manner to blow that off. Probably that patient's going to be hospitalized 3 to 5 days. Over that 3 to 5 days, using some ventilation, having some breathing treatments, maybe with that supplemental O2, we've blown off the CO2, we've rested those accessory muscles, and so now they're feeling better. Now that they're rested, they can start carrying a little bit of that load again, and so the patient is feeling much, much better. However, the moment they stop using it, that cycle's going to start over again. They're going to continue again, wear down that muscle just like they do if they're curling those biceps. And so this is why we want to intervene early. We want to get them on the therapy to rest those muscles so that they can carry the load. Because even though a patient may use non-invasive ventilation at night, it's fine at night. They're going to blow off the CO2, rest the accessory muscles. But the moment they wake up and they come off with it, that's going to start again, right? Because they're going to carry more and more of the burden on the accessory muscles, respiratory muscles, and those are going to fatigue, if that makes sense. So that's what we're looking at, is how do we prevent that from happening, okay? So a lot of times doctors ask me, well, when do you think patients are right for non-invasive ventilation? And typically my answer is always when supplemental O2 is no longer enough. And the reason I say that is because I see it all the time, and I use this analogy. I'm in a physician's office, I see the patient sitting in their waiting room, and they have an elevated respiratory rate. So what I mean by their supplemental O2 is no longer enough is we're no longer able to keep them in a normal respiratory pattern, meaning their saturation is, they can't keep it above 90%, and the respiratory rate is above 20. If 12 to 20 is normal, of course, anything above 20 is considered to be abnormal. And so it's that patient that's sitting there on supplemental O2, yet they're still breathing 24, 28 breaths per minute. They're really, really working. That's a great indicator that they're going to wear those accessory muscles out. They're breathing so fast. They're breathing fast because they can only take these really, really small breaths. And of course, the moment they get up and they start walking to the exam room, now their respiratory rate is going to go up even higher. And so that's why that's a perfect time that we can see just adding supplemental O2, breathing treatments alone are not enough. And now we need to start considering some type of ventilatory support to help that patient. So how does NIV help? So NIV helps in really 3 different ways. The first thing is, and what's very important, is we deliver some type of volume to that patient to make sure they get enough volume, that we get that oxygen and we get down past that obstruction. We get it, we open it up so we improve oxygenation. Okay, so that's the first goal. By doing that, we get the oxygen deeper into the airways where it needs to go so that we can get to the alveoli where that gas exchange is going to happen. So that's goal number 1. But that's not going to make the patient feel super better right away. The second thing is we want to lower the CO2. Okay, again, that volume ventilation, getting that airway open, getting down is going to get past the obstruction and hold it open so that that CO2 can start coming out. That CO2 is not going to come out super quick. It's going to come out every breath, a little bit's going to come out, and eventually we're going to be able to get some of it out, and patient's going to start feeling better. But the real thing is that work of breathing. So if you think about what we're doing with positive pressure and pushing volume in, we're opening up the airway, right? And so what we're doing is we're doing the job of the diaphragm. And because we're doing the job of the diaphragm, now those accessory muscles that have been carrying that workload, they no longer have to. So automatically, we're going to reduce that. And that's what's making the patient feel better, right? When they're on the device, it's doing the workload. The diaphragm can rest. Those respiratory muscles, accessory muscles can also rest. And so it's going to give them some relief. And once they're now well rested, they can come off of it. And for a certain amount of time, they're going to be able to be off of it, again, depending on where they're at in the progression of their disease. That'll allow them some relief. They can be away from it, but eventually, maybe they start at night where they need a little bit more, but then periodically during the day, they're going to need more and more of that support as that disease progresses. Okay, so that's the why. Why is ventilator? How does it help these patients? So when we talk about ventilatory support devices, it's also important to know that there's different types of devices, right? So the first is actual ventilators. We have invasive ventilators, and it's actually the same ventilator. They can be used invasively or they can be used non-invasively, commonly referred to as NIV or NIMV, non-invasive mechanical ventilation. Okay. So usually either one of those are very beneficial. Non-invasive ventilation obviously is the most prevalent, but we also have respiratory assist devices. A respiratory assist device is commonly referred to, it's a bilevel, but it has some type of a volume component to it, right? So normally when we think about a ventilator, we know we have a built-in tidal volume or that volume, but some of the bilevels, not all of them, it's a smaller percentage, but some of them, the higher end, the more complicated pieces have VAPS technology, volume assured pressure support, where we can guarantee a volume because, again, as we just talked about, it's important that the patient get that volume so we get past that destruction or obstruction. We also have bilevel ST, which is just either a bilevel or a spontaneous or time. They can provide some relief, but without that guaranteed tidal volume, they're typically not as effective, as well as a bilevel S, which would just be a spontaneous bilevel. So normally, if we get a patient early enough, and we're going to talk about this, maybe a RAD device may be the best choice, but eventually that patient is going to need the additional features we're going to talk about with a non-invasive ventilator ultimately to treat their disease. So it's important to think about your options to provide the right solution for the right patient. And so here's some examples of some of the different ones, just standard devices that are on the market that are used for patients that go home. Lots of different choices. All of them, they really do the same thing, but they do it differently, right? So when we ventilate a patient in the home versus the facility, especially non-invasively, those patients aren't sedated like they're in the facility. So it's a different type of device. It's not an apples to apples comparison. These devices are ventilators, but they work with a patient who is awake. And so because of that, they all have different algorithms and so forth that make it so the patient doesn't fight the machine, because again, nobody's going to want to feel like the machine's breathing for them. We want it to fit their natural breathing pattern. We want it to work for them. And so sometimes all of these algorithms, because of patent reasons, are a little bit different. So some are better for some patients that like a more aggressive algorithm, some like a more passive algorithm. So that's really where your home care partner can come in, work with the patient, find the one that really works to them, get all of the adjustments titrated and set, and find it to be very comfortable. So this is the first group's kind of standard ventilators. There's an ambulatory one on the market. I think this is going away where patients can use it. For some patient, this could be of benefit. And then there's some that we call multifunction. This device actually has 5 different things in it. They also, this same manufacturer makes one with only 2 that have a ventilator, but may have a cough assist, may have suction, may have oxygen concentrator built in. So we have lots of options. The important thing is to assess those and to assess your patient. I get asked a lot, what is, of all these options, which is the best one? And I always, really give them the same answer. It's the one we have on the shelf. What's important is that we get the patient home, we get them comfortable and stable in their home setting, have the clinician go in, do an assessment, of the home, of their lifestyle. And then once they have all of that information, and the patient again is comfortable and stable, if the clinician at that point feels like one of the other options may be available, then they can work with you to get that patient the best piece. So next, and I know this is a really busy slide, but we really use this to talk about how we manage COPD as a whole, right? Because when we look at it, of using NIV, the vast majority of patients that go into home care on NIV are going to be COPD patients. That's still, as I always say, I like to always have a Will Ferrell reference. So if you're familiar with Anchorman, it's the Ron Burgundy of pulmonary diseases is COPD. But this we call our progression, we call this the timeline. So if you think about this far left edge, that's when the patient's diagnosed. Over to the far right edge, that's when the therapy ends. So obviously, this is just a general representation, and we know the different stages of COPD. They're all represented here: stage 1, stage 2, stage 3, stage 4. They're not equal in time, but what we're trying to show is all of the things, all of the different interventions that may be required for those patients and what that patient really goes through. So from the time the patient is diagnosed till we reach the end, that whole time, that patient's going to have peaks and valleys of increased work of breathing. They're going to have exacerbations. They're always going to be risk of hospitalization. But as we know, COPD patients don't really fade off into the sunset. So they're going to get to a point where as they get into the later stages, and again, they can't use the accessory muscles, they can no longer compensate for the ravages of the disease. We're going to need more and more interventions. And we really reflect that in this gray shading. We talk about that cliff that patients fall off on. Once they get about that stage 3, that's when the hospitalizations really start coming on. And so that's when those interventions really happen. So we start just, when diagnosis, just getting an inhaler, some type of short-acting bronchodilator that a patient may be on. But as that disease has progressed, they're going to get to the point where they can't take a deeper breath. And they don't have good hand-eye coordination. And so that MDI or DPI, that inhaler is not really working for them. They need something more guaranteed, like a nebulizer. They may need long-acting bronchodilators. So they need a nebulizer, right? Because if they don't have good hand-eye coordination, then that medication from the inhaler is going to go to the back of their throat. They're going to swallow it. They're going to get all the side effects, but none of the benefits of the medication. So just like our patient earlier I described that went to the ER, patient comes to ER, we give them a neb treatment, because every treatment that patient takes, every breath, that medication is going to get a little bit further into the airway. And so they're going to get a better treatment. And especially if we partner that with a long-acting medications, long-acting bronchodilators, those are going to keep the airways not only open up the airways, and we have medications to keep the airways from closing down. We have steroids that we can add because, again, if we don't have an open airway, then we got problems. We can start providing oxygen at some point, and at some point, some type of ventilatory support is going to be required. But we don't want to forget that we also have a lot of co-occurring conditions, right? We have bronchiectasis. 40% of our patients with COPD have overlap with bronchiectasis, which means they're going to have a lot of secretions in the airways. And so that needs to be managed. And all of these things need to be managed together because, again, if we don't have an open airway, it's going to affect our oxygen. It's going to affect that ventilatory support. If we have a bunch of secretions, it's going to affect that ventilation support. It's going to affect their oxygen. It's going to affect their neb med. So all of these things work together. In today's medical system, a lot of times these may be provided by 3-4 different companies, the different things. And we always look at it and said, is that what's best for the patient, right? Typically, we don't have one physician managing or we don't have multiple physicians. But this is where we think some coordination of care would be key and in the best interest of those patients. So all of these things are going to come into play. We also have a lot of co-occurring with obstructive sleep apnea, right? We know that's kind of the another really important disease that we manage. And here I've got 15%, but even on some of the studies, I've seen it as high as 35% on the overlap. But those co-occurring conditions, usually bronchiectasis and OSA, usually are going to manifest themselves earlier, really stage 2. So if you think about that OSA, we see this a lot, particularly with us, with our specialized teams. We'll find that patient that has OSA. We've been managing it for years, but all of a sudden they start becoming somewhat symptomatic again, and they're having problems. And it's because they also have COPD, and as they've aged and that disease has progressed, those symptoms of COPD are starting to take over. And so this is when we have to transition from team to team, because we need to manage that patient's, not just their OSA, but we have to manage the COPD. And so that's when an equipment change is very important in that intervention. That's when the medications and all these things line up. So we look at this and say, if we manage this all as a whole, as a healthcare system, then that's going to result in early intervention. That's going to make sure we got consistency of care. That's going to make sure we get the best patient outcomes. And that's going to make sure that we all have stronger relationships with one another, including our patients. So as I look at it, I just, again, so I know we're talking about NIV, but my point in that slide and to look at this one is saying, look, when you're thinking about NIV, don't forget to consider the other interventions that patient is probably going to need, right? COPD is going to need all of these. But if it's a neuromuscular patient, an ALS, they may need the ventilation, maybe not the respiratory meds, maybe not the oxygen therapy, but definitely probably need the airway clearance at some point. So all of these things, just consider them all and how they work together. Because if you're going to help a patient transition to some type of ventilatory support, make sure we're looking at what's going on with their oxygen therapy. How's it working for them? Are they on the right respiratory medications? Because I think that's so important to the overall therapy. Again, respiratory medications can be either inhalers or nebulizers. Oxygen therapy, we have so many different options. We can have stationary concentrators if they're just need it nocturnally, but maybe they need to use cylinders when they're out and about. But again, we want to keep them ambulatory. So we have portable oxygen concentrators. We have really small ones that if we get patients early enough in the disease that are really small, they don't run out of oxygen, and the patients can use them as they go about. And it's really going to give them a lot of freedom. But then we have the much bigger ones. If the patients, as the disease progresses and their needs change, they need more oxygen, or maybe they need continuous flow because the smaller ones only do pulse therapy. Now they need continuous flow. Now they're getting into a larger portable, but it's still portable. But that's going to work for them for a while. But again, as that progresses, eventually they're going to need maybe a home fill system where they fill their cylinders. But my point is, we have to stay with these patients. We have to be constantly assessing them because these needs are going to change all the time as that disease progresses, maybe even as their lifestyle changes. And then, of course, when it comes to airway therapy, we have multiple options here. We have high frequency chest wall oscillation and our vest therapy. We have cough assist if they're having, neuromuscular patients can't get the secretions out. And then there's a new category, oscillating lung expansion, that does a little bit kind of both of those things. So again, some different categories to kind of think in the overall care of those patients. So now we're going to talk a little bit about our coverage criteria. So first, I'm going to talk about, and when we talk about coverage criteria, understand that Medicare is very kind of vague on a lot of this. And so I can only speak to what our interpretation of the criteria is. And so anytime we are looking for a patient to see if they qualify for a certain piece of equipment, we have to relate that to what is known to us. So if we have a payer, a commercial payer, that we have a specific policy, obviously that's what's going to come into play. But when in doubt, we will always go back and refer to what our understanding is of what CMS is actually asking us for. And that's going to be based on our experience, based on our audit history, any reviews that we have, prior conversations that we may have had with them. And so you may find from provider to provider, there may be some little nuances on this. Okay, but we're all trying to do our due diligence to make sure we get the patients the equipment that they need, but make sure that we are doing that in a compliant manner with what CMS is asking. So as I said here on this one, again, pretty busy slide. Basically, what we're saying here is there's no formal guidelines, but we do know the diseases they cover are going to be the neuromuscular diseases, thoracic restrictive diseases, and of course, chronic respiratory failure of a consequence of COPD. So the first thing we're looking for is what is the diagnosis? And then we're looking at the severity. Again, we talked about those RAD devices. We talked about NIV. And so there's some overlap with those diseases. And so we need to, both of those devices may potentially work. And so the most important thing to decide on which is the best therapy is the severity of the disease, right? And so that's huge. But as you can see, even in their wording in this paragraph, 3 times we talk specific. So sometimes we get asked, was there a general statement that we can make? Well, no, it needs to be very specific to that patient. This is what's going on. This is what we're trying to treat. This is what we've decided to treat that. So that's kind of what we're looking for. And then whatever's being ordered, we do need to make sure that we have sufficient detailed information that tell us that justifies what it is, that says, okay, this is what we're trying to treat. This is why. And we see in those notes that we have all the documentation that is very clear to why that's happening. It's also important to understand here that ventilators fall under to the FSS, the frequent and substantial servicing payment category. So if you have a patient, a ventilator that's ordered under a ventilator code, we need to make sure that they're not using it in a mode, because even the ventilators, they have CPAP, they can do CPAP and they can do bilevel. We can't have a ventilator ordered in a non-ventilator mode, because then obviously it would, that says that a lesser device is the most appropriate option for that patient. So I'm going to talk about those codes now. So the first is E0465. Several years ago, there used to be multiple codes, and we did some consolidation. They really shrunk it down into 2 codes to say it's either non-invasive or invasive. And we've had some additions to that. So E0465 is a home ventilator of any type, but it's used with an invasive interface like a tracheostomy, okay? EO466 is a home ventilator, any type, used with a non-invasive interface. This could be a mask, a nasal mask, a pillows mask, but it also can be a chest shell, which only uses negative pressure to move the chest, falls under that same category. Here recently, over the last few years, a couple new devices have come to the market. The one we talked about a little bit earlier in the multifaceted or multifunction devices, but there's a code called EO467. This is a new code only for that one device currently. And that device, it performs other additional functions. And those are oxygen concentrator has it in there. It has a drug nebulizer. It can do cough assist or aspiration and cough with suction, and then cough simulation. So it has 5 different things. So in order to get that device, it would have to be an order for the ventilation function and at least one of those other 4 modes. And that would qualify that patient for an EO467. We probably see that mostly in pediatric patients and sometimes in our ALS population. The second one is the latest, or the next one, excuse me, is the latest one is EO468. EO468 is a home ventilator, a dual function respiratory device that performs ventilation, but it also has cough stimulation built in, right? And so it's the same manufacturer as the one above. It doesn't have all those functions, but we find, especially in our neuromuscular patient, this one comes in handy because they have the vent, they have the cough assist, both built in, and that can be very handy, for instance, for an ALS patient. Okay, so coverage criteria. We talked about this earlier, but a diagnosis is most important, right? First, we need to know who's the payer, right? So we know what guidelines to look at. Second, we need to know what's the diagnosis. Is a neuromuscular disease? Is it a thoracic restrictive disease? Or is it chronic respiratory failure as a consequence of their COPD? So one of those 3 diagnoses will work. Second, we need to know, again, to determine whether the appropriate piece of equipment is the severity of the condition that the patient suggests that it's a life-threatening disease. If it's a severe condition and it suggests a life-threatening disease, then we know that it is a good candidate and the NIV or ventilation is the most appropriate intervention. We also need to have been assessed some way, looked at alternative methods of ventilatory support, such as that RAD device. And that can be with or without backup rates. We need to know either that has been tried and failed, meaning they were on a RAD device, the patient was, and it didn't work. And therefore, the physician chose to go to the next level device, which is the NIV, or that the physician has considered, but ruled that out and said, I considered it, but I don't think that that is the appropriate intervention for my patient, okay? But they will need to give us, obviously, specific reasons why that they believe that it is ineffective to treat the patient's a disease based on what's in their medical history. And of course, as always, it should be very clearly documented. So in saying that, guys, just keep in mind that there are some payers that want specifically, no matter what they want, tried and failed. They won't let them rule out. But most, as long as the physician has stated in there and made the case that they've considered it, but they are ruling it out because of very, again, specific information in the notes. And then the last thing we're going to need is some type of diagnostic testing that shows us that the patient needs the device that's been ordered, right? This is typically going to be an ABG. Obviously, it shows us that the patient has had ventilatory deficiency. Also, a PFT can let us know that the patient's staging, that they're not able to move the right air. And so either one of those tests can be a diagnostic to let us know the patient needs the ventilator. Okay, so let's talk about some of the clinical differences. Again, this is going to come up a lot, and you may hear, even in your facilities, you may hear it all the time called bilevel or BiPAP. But we're really talking about a respiratory assist device. A lot of times we hear that as semantics. It's the same word, but they're talking about all one device. But we need to understand that there, of course, there are differences, okay? With a respiratory assist device, it provides an adjustable positive airway pressure for patients with certain chronic diseases. Typically, a RAD device is used in non-life-threatening cases, such as, again, same diagnosis as chronic respiratory failure as a consequence of COPD, maybe also obesity, hypoventilation, or thoracic restriction. Typically, the respiratory assist device is going to be an effective therapy if it is not considered life-threatening, because that is not a life support device. Next would be non-invasive ventilation. So non-invasive ventilation provides more advanced ventilatory support and is often used when that RAD device therapy fails. It's suitable for more severe cases, including when interruption could lead to harm or death. Has different modes like assist control, SIMV pressure control. Also has those different modes, those VAPS modes that we talked about, but typically that VAPS mode alone in a ventilator would also have the auto EPAP option on the end of it. That is a ventilatory mode. VAPS, again, is also available on the RAD devices. So that alone on some payers is not justification to just have a non-invasive ventilation. Again, non-invasive or all ventilators can be used both invasively or non-invasively as needed. Okay, so let's talk about documentation and notes. Okay, so, supplier produced records, right? Even if signed by the prescribing physician practitioner, or attestation letters of medical necessity right now are deemed to not be part of the medical record for Medicare payment processes. Sometimes, doctors don't always have everything they did. So there's things, like that bi-level rule out statement, or they need to clarify things in their notes. So they're used to writing addenda, right? Which these are, of course, corrections or delayed entries into their notes. We know that those are going to happen, but they shouldn't be used, to make the whole case. They shouldn't be done routinely. And if they do, they should be part of the medical record. They should be done electronically if that record is. Any handwritten note is going to come under a higher level of scrutiny, just because most we're going to see that most of the records we have are going to be electronic. What we don't want to see, of course, is an electronic, and then the doctor can't come in and handwrite something on an electronic note, because that's mixed media, and that is going to be a problem. It's going to face a lot of scrutiny and a lot of time rejected. So any handwritten notes amending the EMR note, we can't accept those. The diagnostics we talked about, those ABGs and PFTs, we can actually accept those for up to 24 months. We can accept those as qualifying testing, but if it goes over 24 months, by the way, that 24 months is pretty liberal. You may find other payers or providers, that may accept them for 12 months. So it's a good idea to understand how long you can use that testing for. The ordered mode of ventilation is not a RAD mode, as we discussed. We use Parachute a lot. I'm not sure if you guys use it, but we're really talking about any electronic note. Even if we have those, we still need to have some face-to-face notes that support any medical note that we have. And the medical records should always be a individualized plan of care specific to that patient with treatment options like we discussed earlier. Okay, as we said, ventilator-related disease groups overlap condition a lot, right? So respiratory assist devices does have an LCD, and we do use that to determine the coverage for those. The principal categories there that were specified can vary from patient to patient. So again, specific plan, a choice of an appropriate plan, including the determination of whether to use a ventilator or RAD device, needs to be made based on, once again, very specific information about that individual patient. If we go to a claim review, we must have sufficiently detailed information that shows this is the intervention that the physician chose, this is why, and the notes need to support that claim throughout. Standard written orders, or SDOs, are required, obviously, for ventilator devices. What you're going to find, providers need beneficiary's name or Medicare identifier, the order date, a general description of what they're ordering. This may include the HCPCS code, a narrative, or brand name, model number sometimes. Of course, the treating practitioner name or their MPI and signature. And then, the device settings, right? The clinicians in the field are going to need to know what is the settings that device needs to be set up on from their physician. So that's kind of the, requirements. Again, I can only speak specifically there to ours, but there shouldn't be any huge variance between most of them. A lot of time it's on very minor things, but that should be a general idea. Again, we look at that a lot based on our interpretation of CMS guidelines. Sometimes we're going to get a payer and we may not know that they have a different policy until at the 11th hour when we actually submit it to them. And so a lot of times we may have to come back and ask you for additional things. All providers do. We certainly all just ask your patients with this and understand we're just trying to do the best for those patients by providing the right documentation so everything goes smoothly. But now I want to talk a little bit about discharge best practices, right? So again, the most important thing when we're transitioning a patient to home is that we ensure a safe discharge. I think none of us wants that 11th hour discharge where we're trying to rush the patient out. It's always better for you. It's better for us. It's better for the patient if we have plenty of notice that the patient's going to be going home, so that we have everything set up and we get them home quickly and comfortably and all of those things. So as I said earlier, always consider that any additional therapies that patient may need to optimize the therapy that you've already ordered, that you're ordering from them. Again, if you're ordering an NIV, think about the nebulized medications, think about the oxygen delivery, think about all of those things, make sure all of those things are set and working well for the patient. Obviously, we believe you should choose the DME partner carefully. Some of the things to consider is you should communicate with them early and often. Do they have the clinical programs and resources to partner with you to take the best care of your patients? Do they have a good quality control process? What is the patient satisfaction with using them? Are they accredited? And then lastly, track outcomes, right? We talk a lot about we want the patient to live their best life, but are we tracking it? Can we prove it? Can we show that we're keeping them out of the hospital? Can we show that the patient's doing better, that they're living a better quality of life? All of those things, in healthcare, we do this for a special reason. We are empathetic and we want to take care of patients, and we want to see that all of the things that we're doing, that this village is doing together, is working for those patients. So let's talk a little bit more about managing that patient at home. So we believe that a patient should have a high touch approach. So the protocol we recommend, again, is obviously if you're on a non-invasive ventilation, any type of ventilator, that has to be set up and that training done by a respiratory therapist. Licensed respiratory therapist would do the setup and delivery. We believe it's a good idea to do a 24-hour follow-up or visit after the setup to make sure everything went okay, right? Make sure the patient doesn't have any questions, they don't have further anxiety, because again, we know in any new therapy, any new piece of equipment, getting the patient used to it and accepting of it and feeling the benefit in the first few days is critical. Following up at 1 week, 2 weeks, 3 weeks, at the end, again, in 30 days, and then, at minimum every 90 days ongoing, is a pretty aggressive, but we feel that is the most appropriate therapy. But of course, depending on who your healthcare partner is, your DME partner, they may have varying protocols that they use. We believe, obviously, you're going to have, if you have a ventilator out, you need to have 24/7 support available for those patients. They have to have on-call clinicians to take care of them. And we should routinely, your DME provider, be making sure that the patient is compliant or adherent to the therapy, because if they're not, then they're not obviously going to get the benefit from the therapy. Obviously, compliance and adherence is a really big deal, right? So we We need to make sure they're using it, right? It can be done either through downloads, with modem technology is great. Technology's come a long way there. That modem technology allows companies to see what's going on with the patients, to get alerts for struggling patients and those type of things. But just making sure they're using it, verifying that is not enough, right? We have to do a little bit more. You have to encourage the patients to use it. Sometimes the therapy can be a little harder to get accustomed to. And so we want to make sure that we're doing all of the things up front with the patient. If it's non-invasive, of course, working with the different mask, finding that right. That's, again, where the rubber meets the road for the patient. It's very, very important, making sure they got the right device, but encouraging them with some individualized education and instruction. Coaching, goal setting, we think is very important, helping the patient understand their lifestyle. I think I learned a long time ago that if you let patients try to figure things out on themselves, for themselves, they just don't. And so it's important. I always try to stress to them that, I've helped literally thousands of patients had the exact same issue. And so I feel confident I'm going to be able to help you too. Engage and empower them in their therapy. They really need to understand that though this may be difficult, though this is a lot of change, it's not the end, and that the juice is worth the squeeze, that if they do this, they are going to feel better. They are going to be able to do some additional things. I think it's important to talk to patient about their goals up front, because again, what is your goal? And then you focus on helping them get to that goal, helping that patient get to the mailbox to check their own mail. And then once you get there, now maybe you have an opportunity to work with them and get them to the next goal. Maybe you get them to the end of the block and then around the block. And the more and more we do, overall, again, we're not going to get them up and running marathons, but we can get them doing a little bit better. And then lastly, we have to make sure that they're successful on the therapy. It has to work, right? We can convince them it's going to work, but we have to show them, right? Just telling them is not enough. So we've got to ensure that by doing clinical assessments and making sure, is the patient regressing? Are they basically doing the same, or are they improving? That's what we need to see, because that tells us what we need to do. We need to make sure that they're trying to get a little bit better every day. There should be lots of hands-on respiratory care in that home, but ultimately our goal here, all of us, should be that those patients are living and they're not just existing. Again, I talked about increasing ambulation earlier. I think it's very important. I would look and say that make sure you're thinking about the technology and all the technology that's on the market there, and it should be invested in. Patient getting portable oxygen concentrators. Again, if it works for them, if it meets their needs, it makes it much easier for them to get up and walk around, to live the life as close to what they were living before as possible. And so investing in that's very important. I did talk earlier about the ambulatory ventilation. I know it's not going away, but we've seen a lot of success on some of the patients that use that. If you have a patient on PAP therapy, think about, if that's one of the things that they have, make sure they have a travel PAP, because I've known a lot of patients say, oh yeah, I use it at home, but it's just cumbersome for me to take on the road. And so I don't do that. And so they miss days of therapy. And then pocket nebulizers. These are smaller nebulizers that they can take with them. And again, they're going to get that good treatment deep into their lungs that they're going to get from a nebulizer, but it's going to be portable. They should be looking at pulmonary rehab, right? Pulmonary rehab usually comes in starting in stage 2 COPD. I think that's very important to get the patient different, retraining how they're breathing to make it as easy as possible. And then, make sure they have access to a travel program or a network of, if they want to travel by airplane, or if they want to go out of town, that it's made easy for them. And if they go somewhere, that there's somebody there to take care of them if they have problems. We don't want to just constrict them into their home. We want them out and about as much as possible. And then, so outcomes, we think it's important that, we track our outcomes. Like I said, I think, we want to make sure that all of the things that we're doing, this village of ours, to make sure that these patients are living the best quality of life their disease state allows, is we have to track it and we want to be able to show it. And to do that, we need to get both objective and subjective data from the patient. Obviously, we want to talk about compliance and adherence. We want to see, I mean, have they been hospitalized? Have they had infections? Have they had exacerbations? If they are on a ventilator, you know, we want to manage that. We want to manage their airway to make sure, again, that all of those things are working. We have the COPD assessment test if it's a COPD patient to tell how well their COPD is being managed. We have the ALS functional rating scale, the ALS FRS that we could do for patients, ALS patients, to see if, again, if they're improving or doing well. We have board scores to check on their oxygen. We have activities of daily living, overall wellness, and really patient competency. Are they good? Are they competent with their with managing their equipment, managing their disease? And all of those things are things that we should be looking at in order to track and facilitate patient success. And then the other thing is, we think that it's important, I mentioned earlier, that in your home care provider that they be accredited, right? And so one of the things that has just came out with ACHC is they've come with a new accreditation, which is the CRPM distinction. And this is a basically clinical respiratory patient management distinction. It's for specifically for to focus on care by licensed respiratory care practitioners and other healthcare professionals for patients with acute or chronic respiratory conditions. And so they monitor it and manage it outside of the hospital environment. And so the emphasis on this is that there is a collaborative and team-based approach to assessment, ongoing treatment, disease management, and medication. So this is outside the regular accreditation. This is a little bit further. This is, again, what we feel something that's very, very important if you're going to manage these patients, that you have this CRPM designation. The goal is better outcomes, right? Are we reducing COPD readmission, supporting the activities of daily living? All of the things that we talked about that we think is important, all of those things happening. Are we making sure that it's happening? And it takes a lot of work. I'm not going to say it doesn't to meet these requirements. You have to have written policies and procedures, right? You have to have patients' right to formulate advance directive. All of these things, except, you know, refused care, treatment, or resuscitation. It goes into the cleaning, the storage, the safe transportation, delivery, use of all of this equipment, frequency of evaluations, the ongoing and services, patient plan of care, again, providing that 24-hour, 7-day-a-week respiratory services. You have to have those on-call therapists. So all of these things that we talked about in this presentation and recommend, all of these things are in this CRPM guideline. Obviously, we have reached that accreditation thanks to the great work that Michelle and her team have done. All patients receive an initial evaluation and assessment of their needs prior to initiation. POC, if it's reviewed before each patient visit and there's a change, then the RCP communicates with providers. All of this, again, very important performance improvement, but very methodic steps that have to be taken to show that you reach the highest standards of taking care of these patients. So that's the end. I'm going to open it now up to questions. If I can figure out how to stop sharing. Yeah, stop sharing so everybody can see. I hope I didn't go through that too fast, but I wanted to make sure, in interest of time, that we had plenty of time for questions.
So we do, hang on a second. There was, oh, I think that Michelle answered it. There was a question and she was typing the answer to it.
Yeah, Michelle's great about taking care of the questions in the chat. But
so is Michelle on? If you're on, Michelle, can you tell the question and what your response was?
Yeah, absolutely. Yeah, good afternoon, everyone. Yeah, so the question was actually from Lisa. And she said, I realize this is a hospital-based case management conference. However, my question is that can patients receive these devices working with their pulmonologists, doctors as an outpatient, or are they only available to receive while the inpatient? So I did answer that, and absolutely patients do receive ventilator equipment. Most likely it's a non-invasive because our invasive patients are more complex, but they do receive devices as an outpatient. They can work with their pulmonologists or specialists in cases for neuro conditions. And then occasionally we have PCP doctors, if the vent equipment is being ordered, especially early when there's a need for the patient, there might be a challenge with getting in with the specialist or the pulmonologist, but we absolutely do work with those patients on an outpatient level. So that was a great question.
It's a great question. Thanks very much for covering that.
Of course.
That was the only question that I saw. It was a great presentation, Casey. Very complete.
Well, thank you. I appreciate
It
that.
was.
Michelle, is there anything else you wanted to add to it?
No, I was just going to say, really, we really appreciate the time today, and I really love, just focusing in on that clinical accreditation. As Casey mentioned, as an organization, we're always striving to really provide the highest level of care to our patients. As we earn this new distinction for respiratory care, we also earn that in tandem with our standard ACHC home DME or HME accreditation. So the two basically come hand in hand. So it's definitely something we as a team are very proud, because it really is a way for us to emphasize on a collaborative team approach when taking care of our patients. So super proud of our teams and the work that they're doing with our patients. But again, I think Casey has hit on all of the things that we as an organization truly believe that really makes us, kind of sets us apart, if you will. So
That's excellent.
So if you don't mind, I have a question that I would like Casey to speak to. This is Lauren. At MGH, oftentimes, or 99% of the time, when I get a referral to go to the floor to set a patient up on a BiPAP, it's an NIV. So I just wanted to for Casey to speak to that a little bit, and also the emphasis on having to change the language in the notes, because that can often be a little bit of a big blocker for us qualifying the patient.
Yeah, I think that's a great question. And so what Lauren's talking about is, I mentioned earlier that sometimes it gets caught up as semantics, that we think about non-invasive ventilation, but it may be referred to as bilevel or BiPAP, even though the physician may look at it and say, this is a more severe patient, and we do believe that patient needs to be on non-invasive ventilation, right? Not on that bilevel or that RAD device. But it's been called BiPAP or bilevel repeatedly in the facility, even though we can look at the settings and tell it's a non-invasive ventilation. When it comes time to send those notes over and it says bilevel, BiPAP over and over again, and then the orders for NIV, the payer may look at it and say, okay, this isn't jiving, right? Again, those notes aren't specific to that. So are supporting of that. So it's very important that we distinguish throughout the notes that it is NIV. And a lot of times we can come in and the doctor may have to make a clarifying statement that even though, this is repeatedly said bilevel, we can see based on the blood gases and the settings related to those, we can tell that the patient was on NIV, so the patient needs NIV. But that can be a big issue that we're calling NIV bilevel, but I know that's a hard thing to change the way we call things, but that language or semantics is really, really important, and it can cause problems. But just remember, if that happens, there will need to be a thorough clarification of what they were actually on and what the physician really wants for that patient.
Thanks for clarifying that. And I agree, it's very hard to change like the historical references, right? We're slow to be able to be remolded. And, I'm all about like what kind of tools can help with that. And I mean, any kind of written reference tool for any providers or care management departments or stuff that we can repeatedly reinforce with our staff, very helpful. There is an additional question in the Q&A now. What is the expected length of time from order with all the needed documentation to delivery? In her area, it seems to take days.
Yeah. So again, the key thing is with an order and all the required documentation, I mean, our expectation is we would set that patient up the same day. Okay. Now that, typically if we have everything we need, we can move forward with that. Sometimes we don't have everything we need, or we need some type of an authorization. We do have ways that we can get around that with majority of payers. Okay. Now let's also say that let's be realistic with one another. There are some payers that are difficult for us, just like they're difficult for you. And so they drag things on and make it difficult for us. So it's not that we don't want to set them up in that same day, but it makes it very, very difficult. But this is where, again, we need to work together. So the more notice that we can get, the faster we can jump through those hoops of some of those difficult payers have. And I think we all know who they are. And then we can, set those patients up quickly, because we're prepared to set those patients up. Our as Michelle and I kind of are the architects of our program here, we've looked at it and said, we want to set patients up as quickly as possible, get them home, because we know you've got to free up beds, but we want to do it safely. So as soon as we get the okay and we know we're good with the payer, we're going to set that patient up as quickly as possible.
Casey, just to add on to that really quickly, the question doesn't necessarily state if it's just non-invasive. I just wanted to add just a little content on the invasive population. I mean, we obviously have a process for that population because it is more fragile, more complex. So depending on the patient and the needs of the patient and the equipment, it could take several days, a week or so. But again, that really depends on the caregivers, their availability, the training. So there are a few factors that go into that as far as the discharge planning, just because it is a little bit more complex. So I did want to just throw that out there as well.
No, I appreciate that. Yeah, I spoke specifically to NIV because that's what we talked about today. But keep in mind, regardless whether it's NIV, but most especially if it's invasive, the number one goal is a safe discharge, right? We want to make sure when that patient gets home, they're ready, their family's ready, and they're going to be successful.
Exactly. As we've heard about all day, we don't want a readmission.
No, we do not. No, we do not.
Right. So this is all excellent information. So if there are no further questions, Maureen, we can hand it back to you.